to the first journal club of 2018-19. So today we're going to be looking at kind of challenging physical examination techniques as they relate to slap lesions of the shoulder. So just a brief outline of what we'll do. We'll just do a quick review of anatomy. Good to understand the basics before we go into things. We'll look at labral injuries, and then we'll look specifically at slap lesions, and then we'll analyze the two articles that were sent out. I don't know if you guys were able to give them a read, but it's okay. And then just a list of some further reading that I thought was important, but wasn't able to cover in the topic today. So just briefly looking at shoulder anatomy. So it's important to remember that the shoulder isn't just the glenohumeral joint, that there are four distinct joints in it, and that's the glenohumeral joint, the acromioclavicular joint, the sternoclavicular joint in the midline, and then also the important scapulothoracic joint, which can often be overlooked. When looking at it as well, you want to remember that we'll look specifically at the glenohumeral joint because that's where the labrum is, so we'll focus on that. With that, you have the static stabilizers and dynamic stabilizers. So the static stabilizers include the glenohumeral ligaments, the labrum, and the joint capsule. So the GH ligaments themselves, there's the superior, middle, and inferior ligaments. In particular, when the shoulder is in the abducted position, the inferior glenohumeral ligament is going to rotate and prevent anterior translation, so that's an important one to remember. We'll talk about the labrum in the next slide. The joint capsule itself helps with the articular congruency of the joint and also creates this negative pressure within the capsule, so that's actually kind of creates a vacuum which helps to force the humeral head onto the glenoid fossa, which helps to prevent any sort of anterior or posterior instability. Second, the dynamic stabilizers are the rotator cuff muscles, so we know those as our sits muscles, and their main objective is to kind of compress the humeral head into the glenoid fossa as well, and it's also important to kind of counteract the action of the deltoid, so it helps to prevent the humerus from translating superiorly when the arm is raised. And then also the periscapular muscles and the scapular stabilizers are important in that scapulothoracic joint. So what they do is they help with the full range of motion of the shoulder. So it helps to get that acromioclavicular region out of the way of the humeral head when you're going into full range of motion. So these muscles include the trapezius, the serratus anterior, the rhomboids, levator scap, and pec minor. So that's why whenever we are treating sort of impingement syndrome, we always look at the periscapular muscles, and we want to strengthen those muscles to help assist in their full range of motion. So looking at the labrum itself, so it's a fibrocartilaginous ring. It's continuous with the glenoid rim and then blends into the articular surface. It's the primary attachment site for the joint capsule and the GH ligaments. As well, the superior labrum anchors the long head of biceps tendon, and then the anterior labrum anchors the inferior glenohumeral ligament. In terms of its function, it's extremely important where its main ones, it kind of increases the size and the depth of the glenoid cavity by about 50%, which helps to enhance the stability of the joint. As well, it kind of spreads the load over the interface and also assists in maintaining that negative pressure that I mentioned earlier. So when we're looking at lesions of the labrum, they are divided into slap lesions and non-slap lesions. Typically when you get reports from radiologists, they describe it in sort of a clockwise manner, so kind of in a clockwise manner, but it's also divided into these 6 separate sections. And in section 1 and 2 is where you can get some normal anatomic variants, which are often described in the radiology reports. Some non-slap lesions to be aware of are a lesion known as Andrews lesion, which is essentially a purely superior labral tear with no involvement of the biceps plate. You can get, again, a purely anterior labral tear. You can get Bankart lesions, which is an anterior-inferior labral lesion, and then we'll go into kind of glad lesions in the next slide. and reverse Bankart tears, which are posterior, inferior labral tears, so kind of the reverse of the anterior. So again, just looking at some of the other ones. So these are these anatomic variants that I was referring to. So there's a sublabral recess in the sublabral foramen. You can get soft tissue or bony Bankart lesions. As well, you can get glad lesions, which are anterior, inferior, which involve kind of the chondral aspect. And then this ALPSA, which is displacement of the inferior humeral ligament, and then that causes the labrum to kind of displace inferior and medially. There are kind of like a plethora of lesions that we can go through, but for the sake of time, we'll kind of skip through them. So looking specifically at SLAP lesions, so SLAP stands for superior labrum from anterior to posterior tear. There are a number of different mechanisms of injury. The first including repetitive overhead movements, so this is typically seen in throwing athletes, and is usually a combination of certain biomechanical positions that the arm can be in. So really, when they're in the peel back, it's called the peel back, so when they're in this end range of external rotation, it causes traction along the biceps, and then you can get a abnormal humeral head translation, and that can be due to a reduction in internal rotation. And then if you get excessive scapular protraction, those combination of things predisposes a patient or an athlete who does repetitive throwing motions to get in SLAP lesions. And also, the most common one is this excessive sort of inferior traction along the tendon of the long head of biceps. So that's typically with carrying a heavy object. You can get it with dropping and then trying to catch a heavy object. Also, you can get it through traumatic injuries such as a fouche or a dislocation, and then kind of more progressively, you can get degeneration of the labrum as well. So typically when they present, they're going to come in with vague kind of deep shoulder pain. They can have posterior or posterior superior joint line tenderness, and usually they'll be exacerbated by overhead or behind the back motions. Classically, they'll present with mechanical symptoms, irregular popping, clicking, and catching, and as well as weakness and easy fatigue. And if they are engaging in some sort of competitive activity, they don't necessarily need to be a high-level athlete, but they may describe a decrease in their performance. So looking at the four major ones, this was initially described by Snyder. So type 1 is a degenerative fraying of the superior labrum with the biceps tendon intact. Type 2 is the most common one. So this is again a degenerative fraying of the labrum, but there is the biceps anchor then also becomes detached along with the labrum. Type 3 is sort of a meniscoid tear in the labrum with the biceps tendon remaining intact, and then type 4 is that meniscoid tear with the biceps labrum or the biceps tendon also peeled off, and most of the time displacing into the joint. So this is a good sort of figure here where you get kind of the classic picture, and then also what you'll see on arthroscopy as well. So over time, this is kind of expanded into 6 different types. I won't go into all of them, but it's basically a combination of some sort of SLAP lesion with another kind of labral lesion. So this is for your reference. Go through in real time. So when we're doing our physical exam, we kind of get into the meat and potatoes of today. First, you want to start out with your general shoulder examination. You want to do your inspection, looking for asymmetry, the posture of the patient, seeing if their scapulars are protracted, looking for their muscle bulk, if there's any sort of atrophy of any of the muscles. You want to do your palpation. Sometimes they may be tender along that long head of biceps. You want to look at their internal rotation, see if they have any deficits with internal rotation during a sleeper stretch. So that's when they're lying on their side. You test their internal rotation. If there's a greater than 25-degree difference on the affected side, then that's a positive test. Also, you want to look for scapular dyskinesis and your classical strength and rotator cuff tests. So as you can see, there's a lot of SLAP physical exam tests to try and diagnose SLAP lesions. So instead of me just reading through what they are, I figured we'd go through some videos to help to demonstrate them. Okay? So the first one, hopefully this work, is the O'Brien's test. So
Patient flex the shoulders to 90 degrees and bring them into 10 degrees of adduction. Now ask your patient to fully internally rotate and ask him to resist downward pressure. For the second testing position, ask your patient to fully externally rotate so that his palms are facing the ceiling. Now, give downward pressure again and ask him to resist.
okay, so that's O'Brien's. Everybody knows speeds. Going to do a refresher on that. Looking more at resonance and show it. Sorry, I have all the times written here on my computer.
The patient to extend his elbow and fully supinate the forearm. Then the patient flexes his shoulder from 0 to 60 degrees while the examiner gives resistance. This is probably how Spencer Speed discovered the test himself, as he was experiencing pain in the shoulder when he was performing a straight leg raise test in his patients with an outstretched arm. In the second version, which is the version that is commonly used nowadays, the patient is asked to extend his elbow, fully supinates his forearm again, and brings his shoulder into 90 degrees of flexion. In this position, the patient is asked to resist downward pressure. When a patient's arm is...
Thought that was just interesting for more of a historical context of speeds, which I wasn't aware of. This is compression rotation. So this one we're sort of lying them down and kind of pressing axially into the humerus and rotating as you compress. And as you can see, a positive test is going to be kind of that uncomfortable clunk or pain, and you can kind of do it in different positions to see if you can try and trap them into it. Just different angles there. So this one is the dynamic labral shear test. It was in one of the other studies that I looked at, but not in the ones that we're going to go through today, but I still thought it was good to go through.
This with one hand, while you apply an anteriorly directed force on the proximal humerus near the joint line with the other hand. Then elevate your patient's arm from about 90 degrees to 150 degrees. This test is considered positive for a slap lesion if your patient reports pain or if the examiner feels a click in the patient's posterior joint line between 90 degrees to 120 degrees of elevation.
So this is the biceps load 1 test, where bring the patient to abduction and external rotation at 90 degrees, and you ask them to flex the arm. You basically want to bring them into external rotation until they feel apprehension, as it says, and then the positive test is if there's no change in apprehension or if they have pain. So that's that one. And really the only difference with the biceps load 2 test, you'll see, is
The biceps load 2 test.
They bring them into more...
Have your patient in supine position and bring the shoulder into 120 degrees of adduction, and the elbow has to be flexed to 90 degrees. Then ask your patient to flex the elbow while you, as a PT, give resistance.
And there's no external rotation, so those are the 2 differences. So more abduction and less external rotation in comparison to the biceps load 1. And then this is the resisted supination and external rotation, also known as a labral tension test. Here, same thing as the biceps hold 1, you bring them into that kind of external rotation with apprehension, and then ask them to supinate from a neutral position. Okay. And then this is the anterior slide or Kilberg test. And here you're going to be applying kind of an upward and superior force along the humerus. Again, trying to compress that labrum. And finally, the Whipple's test. Bring them into forward flexion and adduction, and then ask them to resist the upward, the downward force that you apply. Okay. Any questions? Any of those? Good. Okay. So obviously, there's a lot of different tests that we do, and sometimes in clinic you don't really know, or at least I've noticed so far, is which are the right tests to use, and if there even is a right test, then should we be doing any of these tests? So in order to help do this, I just developed a pretty simple clinical question. So which physical examination tests are the most helpful in diagnosing a SLAP lesion, and just did a very simple PICO search and came up with 2 articles that we'll go through now. So the first one is entitled Clinical Assessments of Physical Examination Maneuvers for SLAP Lesions. It was published in 2017 and was actually done out of Western and McMaster University. So their purpose was to determine whether existing physical examination tests to diagnose SLAP lesions were accurate in patients who present with shoulder pathology, and then secondarily to determine if they were able to distinguish between lesions that were repairable or not repairable to surgery. So the patient population were patients who presented to the shoulder clinic for a first consultation for any sort of shoulder pain or disability other than a referral for shoulder replacement therapy or shoulder replacement surgery, and they were assessed by 4 different orthopedic surgeons who had a specialty in shoulder operations. So in order to identify which tests they wanted to do, they did what's called a modified Delphi process, which is essentially they handed out questionnaires to each surgeon and asked them which physical exam maneuvers they use and what their reasonings behind it were. And a test was chosen if the majority of them agreed upon it, which was 4 to 5 surgeons, but they initially only said there were 4 surgeons doing the test, so I didn't know where the extra surgeon came from. So then they essentially repeat that process by giving the surgeons the other committee members their reasoning, and then they just keep going through that until they come to a consensus. And their consensus was to test these 7 exams here. So basically what happened is that the patients presented to the clinic, they did a self-reported questionnaire. Then the doctors didn't see that questionnaire. They came in, did their regular H&P, and then the doctor reported on a pre-test probability of 8 different shoulder pathologies. So whether that was a rotator cuff tear, AC joint pathology, SLAP lesions, other labral injuries, and then instability of either anterior, posterior, inferior, or multi-directional. So based on that pre-test probability, they said if you were below a certain threshold, meaning that they were 100% confident that like for example, a SLAP lesion was not contributing to their pain, then they were excluded from it. And then on the other side, if they were so sure that it was a SLAP lesion, they decided that there was no need to do a physical exam. Those patients were excluded from the study, and if they fell anywhere in that sort of range, then they had the physical exam tests done. Does that make sense? It's a little confusing to read. So then they performed the tests, and the reference standards were either arthroscopic surgery or having an MRI performed for those who chose not to undergo surgery, or if there was some sort of contraindication. So in total, they had 174 patients. 81 of them were suspected not to have a SLAP lesion, so essentially below that testing threshold that they described. And 93 underwent the physical exam. So 56 had surgeries, 37 had underwent MRAs. Of the 93, only 30 of them actually had SLAP lesions. And if you look at it even further, only 6 of them had isolated SLAP lesions. So pretty rare to have just a SLAP lesion. The average age was around 33 with a pretty wide difference. So when we look at the certain tests, so just to orient you, so the top table is just purely diagnosis, like SLAP lesion positive, whether on imaging or on surgery. And then the second one is they repeated it, but disease positive was the SLAP lesions being repairable on arthroscopy. So as you can see, and I'm sure you realize, most of the tests were pretty poor indicators of disease. The test that had the best combined scores was the active compression test at a sensitivity of 33 and specificity of 61. The compression rotation test had the best specificity at 92. But when you look at the positive likelihood ratios, most of them were all around 1, so not really clinically significant, with the compression rotation the only one really approaching 2 even close. And there wasn't much of a change when you looked at whether they were repairable or not. The sensitivity did increase for the majority of them, but again, same sort of thing with positive likelihood ratios around 1. Again, the compression rotation having the highest positive likelihood ratio there.
Can you just go back one slide?
Sure. Yeah.
So you see the type 2 SLAP lesions?
Yeah.
N of 12.
Yeah.
And then beside it, it says biceps tendon pathology 0. They mean like biceps tendon distally? Because it's part of a type 2, so how can you not have...
Right. Yeah, that's a good point. I didn't realize that. It must be
biceps tendon, I guess.
Yeah.
Tendinitis.
Yeah, muscular bias. Yeah. Okay. So then they tried to see if combining the tests would help to increase anything, and it provided pretty minimal improvement in the sensitivity and specificity. But again, nothing clinically significant as positive likelihood ratios, again, just in around 1 and really wide confidence interval. So there's really no optimal tests that were found. So some of the strengths of this study, I felt that they did a pretty good job in mimicking what a real life clinical scenario would be, especially for us as primary care sports medicine physicians, being that the patients were selected regardless of what their presenting complaint was, except if it was for shoulder replacement. They included patients who both underwent surgery and who did not undergo surgery and had imaging to help with their diagnosis, again, which is pretty applicable to us. One thing that I thought was good as well is that they described really a regimented checklist that the surgeon had to go through when doing the surgery, so that helped to kind of standardize things across all of them, across all the different surgeons that were doing it. And one of the main things that they talk about in the discussion is how these initially high sensitivity or specificities described by the original studies of the test were actually performed by those who developed the test, so they're inherently biased in a variety of different ways. So one of the strengths here is that these researchers were not the originators of the tests. As well, the surgeons didn't have any they were blinded to any previous imaging findings of the patients. Some limitations were kind of detection bias, so you have the same doctor doing the physical exam and the surgery, so you're more likely to find positive results. But they also tried to mitigate this by having kind of a researcher assistant in the room telling them what a positive test was and how to do the test properly. Again, with most of these studies, small sample sizes and wide confidence interval make it difficult. And again, this whole sort of testing threshold wasn't really well described. I do understand that sort of like your clinical acumen is important in determining which physical exam tests you're going to do, but like, are they missing patients on one side or the other that had SLAP lesions? This is kind of tough to say. And as you'll see in the next one, they didn't look at how the tests specifically look at different types of SLAP lesions. So if there's a difference between them.
Go back to the slide.
Yep. This one?
Yeah.
Yeah.
Sort of what you alluded to, how do you think these results would have changed if they hadn't excluded patients with a high pretest probability for SLAP lesions?
I guess it probably would have falsely elevated them as well, because it'd be more likely to have positive tests. So you mean people that were like above that testing threshold? Yeah, I guess it would kind of lead to sort of some of the other biases that were present in the other studies.
But what do you think it would have done to like sensitivity and specificity overall?
Probably would have increased the sensitivity of the tests.
Or both? Or both? Right? I don't know, okay.
Yeah, I mean, if the high likelihood pretest
Yeah.
probability, yeah, absolutely, it would increase both.
Yeah.
How many did they remove again?
They don't say how many were. It said not suspected to have a SLAP lesion. So I assume that to mean that they were below that testing threshold. So they never really did. They never really said which ones were found to be above that testing threshold.
The other thing that's strange is, didn't you say the type 2 was more common than that? That's, we have 12.9%. I think 40%. I thought it was 40 or 80.
You mean in like the general overall? Go back where, sir?
Go back to the orthobullets prevalence of each type.
Oh, that was the overall prevalence. This is just their prevalence in.
Yeah, they're just comparing for that next one.
Oh, right.
Darn.
Yeah, it's like 41. Yeah, it is the most common. Yeah, 41%. Yeah.
That could give us some sample size limitations, actually.
Yeah.
Right.
Well, even type 3 is underrepresented then in their sampling, right?
Mm-hmm.
So what's over there?
Yeah. Yeah. They only have one type 3.
70 for type 1 too.
So.
Oh, that's completely unknown.
Yeah. Yeah.
Yeah, so that's
Yeah. So, sort of their conclusions from this were that really no test in isolation is sufficient to diagnose a SLAP lesion, and then combining them also provided minimal improvement. And really the main thing in the discussion is kind of cautioning patients on the biases of the original studies, and to be cautious when basing treatment decisions solely on physical exam tests, and to always really confirm things with diagnostic imaging. So the second study is evaluations of various physical examinations for the diagnosis of type 2 SLAP lesions. It's published in 2008, so it's a little bit older, but I actually thought it was a really good study and had some clinical relevance that we actually used in clinic today a little bit, so I think it was good to go through. So the purpose of this one, they stated, was to evaluate the sensitivity, specificity, and predictive value of 10 different physical examinations for the diagnosis of type 2 lesions in younger and older patients, and they hypothesized that the tests would be able to differentiate between lesions that had a bicep anchor intact versus ones that were detached, especially in younger patients, they say. So they had 297 patients that underwent arthroscopy. Of those, they developed an index group of 68 patients who had type 2 SLAP lesions, and 26 of them had isolated lesions. And then from that, they had a control group of 78 age-matched patients who did not have type 2 lesions but underwent surgery around the same time, unless they had these exclusion conditions. So just looking at sort of the demographics of the two groups, they're pretty similar, except for the index group had a significant amount less females, and they did then divide the groups into an older and younger group, with 40 years old being the cutoff line. And interestingly, of the 26 with isolated SLAP lesions, 15 of them were below the age of 40, and of the ones that were above 40, none of them were over 60. So everybody was less than 60 with an isolated SLAP lesion. So they examined 10 different physical examinations. Some of the ones we didn't cover previously, but ones that we're all pretty familiar with in terms of Jurgensen's, anterior apprehension, relocation tests, and bicycle groove tenderness, but all the other ones we covered. So what they did is the exams were conducted and recorded by the senior surgeon, the senior author who was also the surgeon, the day before the surgery. And then all the patients underwent arthroscopy. They were subsequently diagnosed with a SLAP lesion based on kind of clearly defined surgical findings. And then they subsequently divided them, as I mentioned, into 2 different age groups. And their reasoning behind this was that depending on your age, you may have different accompanying injuries, which may bias your physical examination. So, for example, in the older group, they'd probably be more likely to have a common rotator cuff tear, whereas somebody who's younger may have a Bankart lesion associated with their SLAP lesion. So they did, again, a pretty relatively extensive examination of the data. When looking at sensitivity, again, none of them were very good. Whipple's test had the Whipple's test, which is again the one that cross flexion, sorry. And so Whipple's test had the highest sensitivity with anterior apprehension, O'Brien's, and compression rotation all above 60. The Jurgensen test had the highest specificity, with Kibler and biceps load 2 tests being the others that were above 70. But again, not one test had good combination of sensitivity and specificity. Further, when you look at the positive and negative predictive values, they're all none of them are very good. They're all within the 30 to 60% range, with 61 being the highest negative predictive value. And then when you further divide that based on age, didn't really make a whole lot of change in the specificity of the speed in the Jurgensen's. There was a little bit, but there was really nothing not one test that was able to diagnose SLAP lesions better in the younger group. So this is where they kind of go, take a next step in their analysis, is they look at combinations of 2 and 3 physical examination tests, and then they further subdivide that into 2 categories of OR as well as AND. So the OR group is ones that the combinations would increase the sensitivity of the overall test, so that means you only really need one of the tests to be positive. In the AND group, it led to an increase of specificity, so meaning that either all or none of the tests were positive. And so these 4 combinations were the one with the highest sensitivity and the highest specificity. So relatively good. Okay. So from there, they then went on, they did a further analysis of the combination of 2 tests, and they found that there was no combination that had a sensitivity or specificity over 60%. So then they went to the 3-tail test. I don't know if 3-tail is the right word, but. So what they did was they looked at 3 tests that had relatively high specificity and 3 tests that had relatively high sensitivity. Okay? So the first one, if you look at in the OR group, so if you combine 2 of, for example, the compression rotation test, or the anterior apprehension test, or the speeds test, then the sensitivity was 80.3%. So this means that if at least one of those 3 tests were positive, you had an 80% chance of detecting a true type 2 SLAP lesion. Okay. The second group is the AND group. So if you look again at that combination of those 3 tests, that means if none of these tests were positive, then that there was a 92% chance, it was 92% specific that you would be able to, that 92% chance of not having a SLAP lesion. Understand? Everybody got it? Okay. So they have this nice figure here saying that 2 of these plus 1 of these, and if you're looking at sensitivity, you want to look at the OR group, and it'll be about 75%. And if you're looking for specificity, you want to do the AND combination, and that'll be around 90%.
Just to clarify, Alex, for anterior apprehension, did they include, like, was it apprehension or was it apprehension and pain?
That's a good question. I would have to go back and double check. So their apprehension was applied to the posterior pain or instability. Yeah, pain or instability.
So anyway.
Yeah.
I mean, I guess I wouldn't call that like pain anterior apprehension, but I guess
Yeah.
in this case they are. Like, do you guys use pain as a positive anterior apprehension test?
You mean for
Like,
when
yeah.
you're testing it.
Yeah, that's right.
Yeah.
Anyway.
So like if you're testing it for a labral, you do it as part of a label test versus as a GH.
But if you want to increase your sensitivity,
But yeah, anyway, so.
So their discussion again, sort of saying if you combine 2 relatively sensitive tests with 1 relatively specific test, it'll increase your diagnostic accuracy for type 2 lesions. And they describe this as being important because different types of SLAP lesions have different clinical features. So specifically for the type 2 lesion, if you provide tension on the biceps and impingement of the labrum, you're more likely to exacerbate their symptoms. And this can lead to different sort of surgical techniques that would be used for the repair. As well, it's also the most common type of lesion that we're going to see. And again, similar to the other study, there was no single physical exam that was diagnostic of SLAP lesions. So some of the strengths of this, I thought again they had kind of strict diagnostic criteria on arthroscopy. They did a pretty extensive data analysis both with the combination, and they included negative and positive predictive values which weren't included in the previous test. And they did attempt to account for age-related differences, although they didn't really find that difference. I did sort of commend them on that. I thought it was good. In terms of their limitations, it wasn't done at a tertiary care hospital, so they are more likely to have patients with pathology. I thought that, compared to the previous study, which had patients on their first presentation, this, when the exams were performed, was kind of iffy, and they didn't really describe it very well in terms of coming in the day before surgery. So they had already been consented for surgery, so therefore they're probably more likely to have positive exam findings in and of themselves. So yeah, I found that to be one of the pretty strong limitations to the study. As well, they did a good job at trying to find an age-matched control group, but ideally the best one would be a healthy control. And then obviously the results are compounded with concomitant shoulder pathology. So again, their conclusion, there was no pathognomonic physical examination for SLAP lesions, and then doing these combination of tests can help to increase your diagnostic accuracy specific for type 2 lesions. So in conclusion, this is just sort of a summary slide. I won't go through everything. But I think really the take-home point is that when you are suspecting SLAP lesions in your patients, to not solely rely on your physical exam, but to kind of take into account the entire clinical picture. So that includes the patient's age, their risk factors for other concomitant pathologies, what sort of activity level they're doing, as well, as their age, are more likely to have degenerative changes included. So I think that's really the take-home point here today. And these are just, I'll include these in the one-page summary that'll be sent out either tonight or tomorrow. I thought that this one in particular is a good overall one. So it looks at pretty much the physical exam techniques for all different shoulder pathologies and the evidence behind it. Recently got published in the BMJ. And then just some other good studies to give a read on your own leisure. And some references. Questions?